Hello and welcome to lectures on cardiac morphology and congenital heart disease. This video is on complex anomalies part 2, the Fontan operation. So we'll look at specimens with single ventricle, main left ventricle, and rudimentary right ventricle. And next we'll look at a single ventricle with tricuspid atresia and rudimentary right ventricle and a small muscular VSD. Then we will look at a single ventricle with the main right ventricle, dextrocardia, left-sided right atrium, after a Fontan operation with the intercardiac lateral tunnel with fenestration. And finally, we will look at AV septal defect that has a Fontan operation, but the extracardiac lateral tunnel type. So let's go ahead and start. So when we say a single ventricle, we don't necessarily mean an actual single ventricle. Sometimes we would have a functionally single ventricle, and the other ventricle will be rudimentary or small, so that physiologically there's only one ventricle that is doing the work of the heart. And this can be of two ways, either a dominant right ventricle, like in the case of hypoplastic left heart syndrome, where there is a small rudimentary hypoplastic left ventricle and a dominant right ventricle, or we can have a dominant left ventricle and a rudimentary right ventricle. In both cases, the rudimentary ventricle has to be sacrificed, and the pulmonary circulation will have to depend on the passive venous systemic return to the lung rather than passing through the heart and being pumped by a chamber from the heart to the lungs. So that's why it is in the end a functionally single ventricle. So let's look at the external anterior surface of this ventricle, and this is the left appendage here. And if we pay close attention, we see that this coronary artery that crosses the anterior surface, which demarcate the ventricular septum, is actually horizontal. So it is not vertical like usual. It is horizontal and crosses to the other side, and it demarcates and defines the right ventricle. So this is the right ventricle, and as you can see, is small and rudimentary, and this is the ascending aorta arising from this small right ventricle. And this is the large dominant ventricle. In this case, it is a left ventricle, as we will see when we look at the interior. So this is a classical example of single left dominant ventricle. Now let's open this heart, and we'll see that this is the ventricular septum, horizontal, and inferior to it is a morphologically left ventricle. We can see that the AV valve has no attachment to the ventricular septum, which is one of the markers of left ventricle, whereas the superior chamber here is a right ventricle, as you can see from the attachment. Now the inflow can take different shapes to the ventricle. Because of the ventricular septal defect, there may be straddling of the AV valve, and inflow can be to two ventricles or both ventricles. However, in this example, we can see only one left-sided mitral valve, morphologically mitral valve here, which opens into the dominant left ventricle. However, you can have sometimes two AV valves as well, opening into both ventricles. This inflow will communicate to this anterior chamber, and from there into the ascending aorta through the ventricular septal defect, or what is also called bulboforamen ovale. Here, where might be a pulmonary artery originating as well, unless if there's pulmonary atresia. This interventricular communication is also called bulboforamen ovale here, because it connects the embryologic anterior chamber, which is called the bulbus cordis, right there. That's the bulbus cordis with the left ventricle. So some authorities call it bulboforamen ovale. So one of the problems in this lesion that this bulboforamen ovale is not a static condition, and it can get stenotic with life. As you can see, when the heart grows bigger, this communication can restrict flow to the aorta and therefore to the systemic circulation. As you can see here, there's an obstruction to the systemic circulation. The pulmonary flow has also been sacrificed in this particular case, and the pulmonary artery has been supplied exclusively by systemic flow in a controlled manner by this BT shunt that we see here. So this was a classic example of a univentricular heart of the left ventricle morphology. So let's put this aside and let's take a look at this other example that we have here for you. Now, in this heart we can see the ascending aorta right there, and this is a small pulmonary artery here, and this is the coronary artery delineating or demarcating the interventricular septum with a dominant ventricle here and a smaller ventricle there. So this is a normal right and left ventricular relationship, but if we look at the left ventricle, it's very hypertrophied, and we have two ventricular septal defects, one here and one up here. So if we look at the right-sided small ventricle, we see that it is of a right ventricle morphology, and it connects to this pulmonary artery. And if we look here at the orifice of the VSDs, we can see that sometimes it's difficult to see. However, in this case, we do actually see them, one here and one there. And with time, and due to the increased hypertrophy of the left ventricle, these orifices may become smaller and smaller. So in both of these examples, we have a rudimentary chamber. However, in the previous example, the rudimentary chamber gave rise to the systemic circulation. Here, it gave rise to the pulmonary circulation. And in this example, the dominant ventricle gave rise to the systemic circulation to the aorta. So although the ventricular anatomy is the same, but the connection and the physiologic effect is different. And in both cases, we will need to have a systemic supply to the pulmonary artery. And in both cases, a Fontan operation is the rule. All right, so let's take a look what we have next for you here. Okay, let's take a look at this sample. So in this specimen, the apex of the heart is to the right, if you look closely, and the right atrium here is on the left side. So this is a situs inversus heart. This is the right atrium. And if we open the dominant ventricle here, we can see that it is of a right ventricular morphology. However, the anatomy is so complex that the heart has to be treated as a single ventricle. Now, we can see that this is the right ventricle because if we look at the aorta, which is rising from here, we can see this definite infundibulum that separates the ventricle from the great artery. So if we open the right atrial wall, we will see here what the surgeons have created, which is the lateral tunnel, which is also a part of the Fontan operation. This tunnel will separate the systemic venous return from the pulmonary venous return. This is where the inferior vena cava comes and the blood flow is routed straight superiorly to the lungs, right and left branches. This is the superior vena cava also flowing back into the lungs directly, whereas the pulmonary venous return will come back to the systemic ventricle and go out to the aorta here. That's the lateral tunnel. And if we pay close attention to this lateral tunnel, we see this fenestration right here, which was intentionally created by the surgeons to regulate the pressure and help in reducing the pressure in the Fontan circulation in cases where the pressure rises up. And sometimes it can be also bidirectional flow. This fenestration can also be closed later on by a device when the patient doesn't need it. So that's the fenestration in the Fontan baffle. So let's look quickly at the internal morphology. In this case, it's not very important. I just wanted to show you the lateral tunnel. So the systemic flow arises from here, where the pulmonary venous return drains into that main chamber, and this main chamber drains into the main ventricle right here. Okay, slippery a little bit, and this ventricle gives rise to the systemic circulation by the aorta. Let's take a look at this next specimen, where we will see another variation of the Fontan operation, which is the external tunnel. In this specimen, if we open the heart, we see that we have a large ventricular septal defect, and here's the ventricular septum right there on this side, and here's the ventricular septum on this side. And here we can see this right ventricle, and this is the left ventricle. And we see a common AV valve, and it was not possible actually to septate this heart because of the morphology of this common AV valve and the relationship to the ventricular septum. So a decision was made to turn it into a single ventricle and a Fontan operation. However, in this case, it was done using an external conduit, an external lateral tunnel connecting the inferior vena cava to the pulmonary flow superiorly. So there are many variations for this surgery, as you can see. So thank you very much for your attention, and we will see you in the next video.